Welcome everybody. My name is Malik. I'm one of the interventional neuroradiologists working here at Nottingham University Hospitals. I'll take you through aneurysms, neuroaneurysms, as part of this talk. So I'll just tell you about aneurysms to begin with and why they are a problem. And we'll take you through the extreme of in detecting aneurysms. I will talk a bit about the different types of aneurysms, and ultimately we'll spend most of our time talking about how to tackle each of these different types. I guess an aneurysm is, as you know, is a focal outpouching, a focal localized dilatation, and the main problem is that these outpouchings are prone to rupture. Now, they're a lot commoner in the general public than we think, so up to 3%, and some population studies even show up to 5% prevalence of aneurysms in the adult population. So if I was to scan 100 random people on the street who are adults, it affects females twice as often as it affects males, and it is the leading cause of hemorrhagic stroke. And when a patient presents with a subarachnoid hemorrhage, there's an 85% chance that it's due to a spontaneous subarachnoid hemorrhage, that is, not traumatic, 85% chance it's a brain aneurysm which has caused it. And when you do have an aneurysmal subarachnoid hemorrhage, it is an overall 5% of all strokes. So again, it's quite a large disease burden, and particularly when you take into account that ischemic strokes often affect elderly population, whereas aneurysmal hemorrhagic strokes affect relatively young people. Despite only being 5% of overall strokes, is actually comparable to ischemic strokes. Now, in the UK, what we know is that when aneurysm bleeds and ruptures spontaneously, up to 15% of patients don't make it to the hospital, so it's obviously a life-threatening event. Even the ones who survive and have treatment, there is up to 30% mortality, and some of them are left severely impaired. In terms of risk factors, they're quite important to consider. Various population studies have demonstrated that, well, there are loads of loosely connected risk factors, but there are only three which have clearly been demonstrated to have a direct impact: is having a strong family history of aneurysms, having high blood pressure, which reveals a lot of the aneurysmal development etiology is thought to be due to flow dynamics. And the closest secondary risk factors are your connective tissue disorders. So lifestyle can definitely have a clear impact on developing and enlarging aneurysms. In terms of etiology of aneurysms, it's not so clear, because depending on what exact type of by commonest type is a saccular aneurysm, which is the focal outpouching, as you're seeing in the sort of picture A, has a sort of a narrowish neck and a broad dome. However, they can come in all sorts of shapes and sizes. They can be distal microaneurysms, a fusiform type aneurysms. I'll go into more detail a bit later on about these. But essentially, they can all have a variety of different pathophysiologies. The commonest pathophysiology is thought to be affecting saccular aneurysms, which is, like I said, by far the most common forms of brain aneurysms. It's thought to be shear stressed at bifurcation points. And since there is most turbulent flow at the points of bifurcation when an artery divides into two, any sort of intimal injury at that point can over time come up as a blister and then further grow with the flow hitting the aneurysm, the blind ending sac, and over time that can increase in size and eventually look like what we recognize as a saccular brain aneurysm, a brain aneurysm. And these are prone to rupture. Here's a diagram that shows the distribution of how often we find them in what locations. The commonest locations are these four that have been listed here. That's the anterior communicating artery aneurysms, posterior communicating artery aneurysms, a middle cerebral bifurcation aneurysms, or basilar tip aneurysms. Having said that, if this pathophysiology and this etiology, if we know it to be true, it can affect any bifurcation point. And in fact, that's in clinical practice. Yes, these are the commonest sites, but you can see it at any point. The typical configuration of a saccular aneurysm is a neck which connects the parent artery with the sac of the aneurysm, and it has a well-defined outside margin with a clearly defined dome. And when we're talking about microaneurysms, which are far, far less common, there are two main varieties. So you're either getting them they're usually in much smaller vessels, so you tend to get them in a vessel size even less than 0.3 millimeters. So they are often found in these sort of locations in the basal ganglia arteries. So these arteries are coming off your middle cerebral artery, and they're known as your lateral lenticular striate arteries. They supply the basal ganglia tissue here. And these microaneurysms have an eponymous name. They're called Charcot-Bouchard aneurysms. They're seen in patients with chronic hypertension. However, they can also be seen in end arteries, so much more peripherally, as the arteries subdivide into tiny little vessels over the surface of the brain. And those aneurysms, more often than not, are a result of an infectious source. So it's a septic embolus in somebody perhaps with an infective endocarditis, or less commonly, but also we've seen, I'll show you an example of this later, is traumatic microaneurysms distally. These are quite tricky to treat, and particularly in the case of hypertension, microaneurysms, they are rarely treated, and I'll show you an example of this later. When aneurysms, the saccular variety, or when they are larger than 25 millimeters, they're referred to as giant aneurysms because of the degree of mass effect on the surrounding tissue and how it sort of relates with the surrounding environment impacts on how likely it is to rupture. Like it says here, that unlike smaller saccular aneurysms, untreated giant aneurysm, quite often they're not picked up after rupture because mass effect can be the reason why they present, whether that's because it's causing hydrocephalus, it's compressing the ventricles, or whether it's causing compression of the brain tissue and there's direct symptoms of focal neurology as a result of that, seizures, etc. Either way, they have some of the worst prognosis, and they probably have, despite being a small proportion of overall intracranial aneurysms, they have the poorest prognosis. A fusiform aneurysm you'll be very familiar with when you're thinking about a classic abdominal aortic aneurysm is a classical example of a fusiform aneurysm, where you've got widened and thin segments of the artery with sort of diseased thrombosis, clot, and thrombus aggregation to the walls of the aneurysm as a result of sort of intimal damage and sort of the downhill sort of spiral of that. Here's an example in the brain aneurysm of seeing something similar. So you've got I'm not sure if this is projecting very well, but you've got two vessels coming off here. This branching point, there is a well-defined round sac with a defined neck aneurysm, whereas the fusiform aneurysm incorporates almost the entire circumference of the vessel itself. So for it to be really technically called a fusiform aneurysm, it really ought to affect more than 270 degrees of the vessel circumference. And here you can see that the entire artery appears diseased compared to on the other side where there's a focal outpouching. You can imagine how these can, as a result, be very tricky to treat because you need to try and save the parent vessel, but the parent vessel is entirely involved. I'll show you some examples of this later. We'll also look at some special types of aneurysms, the dissecting aneurysms, blood blister aneurysms, and a specific type of giant aneurysm, which is essentially what's called a giant serpentine aneurysm. What happens in a very large sac is that you start to develop thrombus. So this is an aneurysm, the ACOM location. You've got this very large sac, and the red arrow points to a mixed signal demonstrating thrombus within the sac. And as the different layers of thrombus develop within the sac of the aneurysm, what it can look like is essentially a snake-like configuration amidst all the chronic clot, and that sort of forms this serpentine appearance. They are sort of a low risk of rupture, but because of the size, they can have mass effect and symptoms as a result of it, and they can be very tricky to treat. But I don't have an example of a serpentine aneurysm, but we'll probably be going through all the rest, so I'm going to move on from this. So in terms of clinical presentation, either they are picked up incidentally, so they might be asymptomatic or having a scan for a medical health check, or they might be having a scan for any other reason. The most common incidental pickup that we have is went to GP for a headache, had a GP scan, often an MRI scan, and that picks up an incidental aneurysm. So if it's an adult, then you have a 1 in 20, up to 1 in 20 chance of picking up a incidental aneurysm. Now, so I'll talk about the management of that separately. And the other way we see these patients is when they present to the hospital following rupture of the aneurysm. with subarachnoid hemorrhage plus minus multi-compartmental hemorrhage. So here is a schematic that shows you that this blood, this sort of red represents blood in this diagram. You can see it's sort of going into the different sulcal spaces, which is the subarachnoid space. And the reason why you get subarachnoid hemorrhage with aneurysm rupture is that your blood vessels that are supplying your brain tissue are all within this subarachnoid space. So all the arteries and veins, yes, they do traverse the dural layers, but predominantly the intracranial arteries are stay within this space, and this is the space that we worry about when it comes to subarachnoid hemorrhage. Now, in terms of clinical presentation, the classic thing is that thunderclap headache, which is a sudden onset, worst headache of lifetime, sometimes accompanied by collapse. And people who have actual classical presentation, which is actually quite a lot of patients. So this is I would probably say majority 80% when they describe the headache they had before the subarachnoid hemorrhage at the time of the aneurysm rupture, they do describe it as that classic sudden onset, like a thunderclap type headache. So that the history can be quite a giveaway. And in terms of sometimes patients do present a bit late, and when you take a history, what happened a week ago, and it's that classic case of I did have the worst headache of my life, but I took some paracetamol, went to sleep. So that's kind of your classical history. And as the meninges get irritated, you can also get focal neurology if you also have associated intraparenchymal hemorrhage. So if, for example, the MCA aneurysm also bleeds into the basal ganglia or temporal lobe, you might get focal neurology as a result of it. Now, depending on the blood load, the mental state can also be affected. So patients who are the best grade, so good grade patients they have the classical history, they have subarachnoid hemorrhage, but they are very much with it. They're not confused. They are essentially a GCS 15, whereas the poor grade patients essentially are much lower down in the sort of Glasgow coma scale. Posterior fossa parenchymal bleeds can also lead to vertigo or dizziness. And in terms of the compressive effects, the classical one is a posterior communicating artery growing, artery aneurysm growing and pressing on the ocular motor, getting a surgical third nerve palsy. If there are sort of, if we look at a potential, well, these are rare. This is way beyond the usual that we see. You might see this once every few years. That it may be that there's a history of infection and you're looking at a septic or mycotic aneurysm presentation. So when you do get an incidental aneurysm, as they're usually picked up on CT or MRI, from for whatever reason, they get referred to our regional neurovascular MDT. So for Nottingham is the regional neuroscience centre, which covers all of East Midlands. It's about 4 to 5 million population, and any sort of aneurysm which is discovered is sent over to our neurovascular MDT. Here we have a bunch of my colleagues, so INRs, neurosurgeons, specialist nurses. We recently also have a stroke physician, so a vascular neurologist, and together we discuss what's the best for each aneurysm. So you either decide that it requires treatment, and if so, we'll think about what type of treatment, and I'll go into those details later. Or we think it doesn't quite require treatment, but we can't really draw a line under it, so we'll keep them under surveillance, or we will discharge them to say that, well, either it's very low risk or essentially it's inoperable. So either way, the patient will be seen and discharged. So that's the kind of the paradigm for your incidental aneurysms. We either treat them or we most often keep them under surveillance. Now, when it comes to diagnosis of ruptured aneurysms, often when you get a headache of that nature, very few people tend to sort of sleep it off. If you're lucky enough to survive it, so if you're one of the 80-odd% who didn't immediately die as a result of the aneurysm rupture, people eventually, within the first day or two, get medical help. The first thing whoever's clerking them in at ED, when they hear that sort of history, will get a CT scan to exclude a brain bleed. Now, just a little pause here. This can be quite tricky. So when you are, I know there are lots of medical students here and junior doctors, and everybody tends to describe their headache as the worst ever headache, and differentiate a thunderclap headache and one from which is just a very bad headache. Now, the truth is, you can't differentiate it. But because of the fact that the nature of the condition that you're dealing with and I'll show you the risks of missing a diagnosis, is that you would rather over-investigate than under-investigate. And it seems to be the way with a lot of things these days, but it really is not a diagnosis you want to miss because they're young patients. If it does at all sound like an aneurysmal type severe headache, then they ought to have a scan. And the usual procedure is for them to go on to have a lumbar puncture. And if subarachnoid hemorrhage is confirmed via lumbar puncture or plain CT head, they'll go on to have vascular imaging, most often in the form of a CT intracranial angiogram, plus minus catheter angiogram. We'll come to that in a second. So this is what a subarachnoid hemorrhage looks like. So instead of having CSF in the subarachnoid spaces, CSF is black, as you can see in the interhemispheric fissure, interpeduncular cistern. You've got the Sylvian cistern. So this is what we call a cisternal pattern. If you had subarachnoid hemorrhage entirely peripherally, it's less concerning for aneurysm, and usually with aneurysm rupture, you get a very cisternal pattern, not a peripheral pattern. So a central pattern of subarachnoid hemorrhage. You may also have associated subdural parenchymal bleeds, and if there's a high pressure bleed, what you might also get is reflux back into the ventricles, because normally the CSF is being produced in the lateral ventricle and it circulates out into the subarachnoid spaces. It can start to spill back into the ventricles and you can get ventricular hemorrhage. And overall, that presence of blood can also block the reabsorption, and as a result, the patient can present with hydrocephalus, which in this scan in front of you, there's a very subtle sign of what we call early hydrocephalus. This temporal horn compared to the other side is starting to balloon up, and this is the earliest. So if the CT head wasn't as obvious as that and it was completely normal, but the history was very well, that you haven't missed a subarachnoid hemorrhage, this is what you would do. You'd get a CSF sample to look for xanthochromia. And the important thing to remember is that a lot of people don't know this, that it can be positive for up to 2 weeks post the worst ever headache event. So that's the ictus. So 2 weeks post ictus, it can still be positive. So that's one thing to remember. Whereas it gets harder and harder to see evidence of subarachnoid hemorrhage on a CT scan as the blood sort of starts to get reabsorbed and become more essentially microscopic than macroscopic. The next thing we do in all these patients when subarachnoid hemorrhage is confirmed is we look for an aneurysm or any other arterial abnormality. So CT intracranial angiogram is your fastest, cheapest, most readily available tool. So whether you're having a subarachnoid hemorrhage in Boston or Kings Mill, or you're having it in Derby or a big teaching hospital like Leicester, they all have the same test available. So it's quite a good test to have, as it is can be used across the population. And it can be positive in most cases of subarachnoid patients. It gives you a pretty good detail. So this is a MIP view. So what we do is we maximize the signal of the vessels. So you see them quite nicely on this image. And you can use that raw data on the CT scanner to do what's called reconstruction. So you can remove the bones and remove the other sort of structures and just get the scanner to show you the vessels. And that can be quite handy to see where the aneurysms are, and also for planning treatment. Now, if a CT, in this case, you can see there's an example of a anterior communicating artery aneurysm. So here is a ACA of the right side, that's the ACA of the left side, and here's the ACOM vessel on which there is this aneurysm, and these are the distal right and left A2 ACA anterior cerebral artery branches. But if you were to not see an aneurysm, the next thing we tend to do is catheter angiogram. So this is done. This is gold standard for assessing vessels. DSA is what it stands, what it is, and it stands for digital subtraction angiography. And the way that works is that when you do an angiographic run, the X-ray machine takes a mask image, which becomes a control image, and after that, as the contrast runs through, it takes a continuous series of images. And to show you this classical DSA image appearance, with every image that it acquires, it subtracts. The only thing then you will see is a new radio opaque substance which enters the margin. So essentially, which is just a contrast. Everything else was there before, so it gets subtracted out. So this is how a DSA is performed. It has excellent spatial resolution, so you can get amazing detail down to sub-millimeter structures. And the best thing about it is dynamics, so you'll see different phases. You're actually seeing real-time contrast coming into the arteries, going into the capillary phase, parenchymal phase, and out through the veins. So that dynamic nature of it allows you to pick up even the finest of abnormalities. And although aneurysms is the main thing that we're talking about today, which is by far the commonest thing that we find in sort of a central pattern of SAH, such as arteriovenous shunts or dural fistulas, is a invasive test. So it's done by going and entering the artery in the groin or the radial artery, so femoral artery or radial artery access. You feed your catheter turn by turn in different cranial arteries, your carotid arteries, so that your vertebral arteries, and you do direct runs. That's far more invasive than a CT angiogram. That's why we do this as a reserve test when we can't find the abnormality scan concerned. So this is what the different phases of the scan looks like. The arterial phase, you're seeing all the arteries, and after a few seconds, you've got the sort of early venous phase. The veins are starting to fill. The convexity cerebral veins are filling. And then as you go further in the late venous phase, you can see the dural venous sinuses are filling. And on the sort of early venous phase, you can also see a parenchymal blush, the staining, sort of a light grey staining all across. So if you've got tumors and other abnormalities that may have caused the problem, they can also reveal themselves. So you've done all these tests. Someone's come with a subarachnoid hemorrhage. You've done a CT angiogram and or a DSA for that matter, and you've discovered an aneurysm. Now what do you do? The thing to remember is that if an aneurysm has bled, it has a very high risk of rebleeding again. And if the patient has survived the first event, so if they've been lucky enough to be one of the 85%, and actually some studies quote that up to a third of patients don't survive the initial bleed. And so if you are lucky enough to survive the first bleed, you've got a 72-hour window where the aneurysm has a very high percent, and actually this is thought to be, so this is the trouble with missing a diagnosis, which is why you want to over-investigate rather than under, because if you miss the diagnosis, chances are that they may well bleed again. If they do bleed again, chances are they won't survive the second bleed, even if the first one wasn't too bad. And mortality rate is particularly high when it comes to a rebleed rate, when it comes to rebleed patients. So essentially what needs to happen is these patients need urgent to have a best chance of survival. Now, treatment options for aneurysms are, and just to kind of break them down, doing nothing is only sometimes appropriate, but it's very rarely appropriate. Tends to be in the case where, let's just say it's a very poor grade patient, they've got a very low GCS, and looking at the brain scan, the degree of hemorrhage, the degree of mass effect, the degree of damage to the brain tissue already, you may think that actually it's probably best to not intervene any further. Chances of survival tends to be very low anyway. The mantra of the treatment is that you're not trying to do anything about the blood that's already there. The primary motive of the treatment is to prevent a rebleed. And if somebody's initial brain hemorrhage was very significant, that their GCS is below 7, the chances of them surviving that initial event is not very high at all. Now, in terms of the options of doing treatment, we are talking about either open surgery, so microsurgical clipping. I'll show you some examples of that, or it's endovascular approach. And these days, it's first line in most cases. So 20 odd years ago, clipping was pretty much the only option. And now I'll show you why over time. This is now, I think in Nottingham, particularly 95% of patients are treated with endovascular treatment. In a year, where we do about 300 aneurysm treatments, of which 50 or so are elective patients. So they come to the outpatient clinic after being discovered incidentally, and if they are deemed high risk enough, we offer treatment. By and large, most of these patients they come following rupture. We'll go into each different options available. And where it all changed really was this landmark trial was published in the Lancet in 2002 called the ISAT trial, or the International Subarachnoid Trial. It was run in 43 centers in the world, and the single biggest contributing center in the world towards this trial was actually Nottingham. So this is our claim to fame. And this trial was stopped early by the Medical Research Council because the very first 1 year post treatment scores showed there was a significant reduction in the um, number of patients that were disabled or dead between the two arms, and overall there was a 22% improvement in patients treated with coils. And this is going back, more than 2 decades now. And I have to say that even in the time that I've been in the specialty over the last 8 years, uh, there have been huge advancements in safety profiles of devices, and the tools for the right kind of abnormalities. And I think if this trial was done again, obviously there's no equipoise for it anymore. That difference may well be more stark. Needless to say that the procedure is a lot less invasive, so you don't have an open skull approach. You're going from the inside of the blood vessel. You can reach areas which are inaccessible by open surgery. And as a result, I think what's happened is over the last 20 years, we are not only doing the aneurysms that previously were deemed to be sufficiently clippable, now we are able to treat aneurysms of all shapes and sizes, which were previously thought to be untreatable because of just the various different devices and tools that we have available to us. In terms of a brief overview of surgical techniques, so the most common ones that still prevail are sort of simple clipping um, or wrapping if clipping is not possible. Previously, they used to do things like temporary artery occlusions to see if you can thrombose the aneurysms. This is certainly very rarely attempted these days. And bypass techniques can still be considered very rarely done, but are an interesting approach to some otherwise untreatable aneurysms in which you are trying to bypass a segment of diseased artery by plumbing the proximal artery with a distal segment. But it's a very invasive technique and can be quite tricky to do. One of the things that they do in interprocedurally these days is this microscope integrated near infrared IGC video angiography, which allows them to see patency of vessels. I'll show you some examples of that. So this is um, an image to show you how they approach the aneurysm. So this would be a pterion craniotomy, a dive-in dissection through the dural layers to expose eventually the sylvian fissure. This is thought to be a middle cerebral artery bifurcation with this aneurysm in the middle. And the key is to identify the neck and make sure that there are no other smaller vessels nearby, and then placing a clip across the neck to seal the aneurysm. It's a bit like tying a string around a balloon until to seal it off. So this is the ICG video angiography I was mentioning earlier. It's not something that I've ever we ever get to use, so it's just something of interest. So here's again an MCA bifurcation aneurysm, and you can see the two main vessels coming off, but you are quite blind to what's potentially behind it. So here is a angiography after injection of this material, and you're seeing all the different branches around it. And after placing the clip, you can repeat that process to see they're all still patent. Again, a small minority of patients are having this done. Alternatively, what we can do is by accessing the arteries from the inside, eventually getting fine tubes into the aneurysms themselves and releasing a number of platinum coils. You size the aneurysm and choose the right loop diameter of the coil. And it's sort of like a Russian dolls effect. You start with the biggest, stiffest coil to form a frame in the aneurysm, and you try and fill it with sort of a softer, more pliable, smaller loop diameter coils to essentially get a good pack of metal in the aneurysm. And what that does is it encourages thrombosis of the aneurysm from within. And this is essentially what wrapping looks like. If it's an uncoilable, untreatable aneurysm, you can wrap it essentially in this sort of material and clip alongside it. Speaking to my neurosurgical colleagues, they don't really like doing that because they don't really think it works. It's sort of a thing if you've gone in to clip an aneurysm, but for some reason can't safely do it because of the vessels uh, placed in the area or other anatomical um, restrictions, then this is a sort of a backup option. This is what a bypass potentially can look like, but we'll also skip past this bit and talk a bit more about the endovascular treatments, which is obviously what interests me. And that's what obviously interests you since you are IR juniors, soon to be the seniors in the future. So this is what a biplane theatre looks like. So we do all of our work in a biplane theatre as opposed to the single plane that's required peripheral IR. So here you've got, you can see, this might look fancy, but we've actually just bought two of these machines for QMC. They're soon to be installed. These are your Siemens Icono biplanes. So this has got one plane in this direction, the other one tangential to that. The reason why you need a biplane is because you're often treating tiny little abnormalities amongst areas where very important arteries are coming off. So you need to be absolutely precise. So you need to triangulate on two planes to make sure that you are where you are. Otherwise, the problem with X-rays is that if you're only looking at one plane, you could really be anywhere along that plane and you wouldn't really know, which is okay when you're looking at, for example, if you're doing a popliteal artery angiography, because there isn't really that much anywhere else you could be in terms of the vascular anatomy is not as complex and the risk is lower. Even if you ended up in a small, tiny branch, it's, being in that branch is not going to give that patient a stroke. So this is how it happens. All of our cases are done under general anesthetic, and you access the artery via the femoral or radial artery. Eventually, get a large catheter, or what we call a guide catheter, in the neck. From there, in each angiogram, we do a 3D angiography. There was a rotating aneurysm at the first couple of images. The outline slide had that rotating angiogram. We do a sort of a planning angiogram, which is an extremely detailed way of looking, plan the different angulations and the projections you need on the screen, because that screen will tell you at which angle does each plane need to be for you to be able to get the exact view that you like. And once you've got those views, you will take a microcatheter or a number of microcatheters to then treat the aneurysm. So it could be something as straightforward as this. No aneurysm has ever looked this nice to treat. So this is a perfect aneurysm to treat with a very narrow neck, with a very sort of a good dome to neck ratio. The reason why this is pleasing to the eye is that no matter what size coil you might place in here, it's not going to fall out. The problem is that if you undersize the coil, the neck was much wider, and if you, let's just say the neck is 3 millimeters wide and you put a 2 millimeter coil near the neck, it can fall out and migrate and cause a stroke down that territory. So it would be very nice if aneurysms were like this, but quite often you need help of other devices, either two microcatheters to play and make a conglomerate mass together, or using balloons and stents to assist and protect the parent artery to get a coil to sit in. So this is the example of doing that. This is although it looks crazy complex, but unfortunately is closer to the truth than this is. In which case you've got a much broader neck. So this is an example of a basilar tip aneurysm. This is a diagram to show that because of how broad-necked it is, you're never going to get coils to remain in the aneurysm. So what you can do is put stent devices. They've got sort of stiff wires that have high radial strength, and they can essentially give you scaffolding through which you can keep the coils in the aneurysm. So over time, this will occlude, and the stent will stay open because you'll need to put them on dual antiplatelet medications. Alternative to a stent would be a balloon. I'll show you some examples of this. Other examples of different devices here are intrasaccular devices, which are designed for wide necks. I'll show you them in a second. And these special stents, which have really revolutionized aneurysm treatment, called flow diverting stents. And here's a little example of that over here, which is a much more finely braided, many more wires. It's a very clever stent, and it helps with, as it says on the tin, divert the flow away from the aneurysm. Finally, we can also use liquid embolic agents, rarely, usually for distal aneurysms, often to sacrifice the vessel if it's otherwise untreatable condition. So we'll go through some examples. So here's an example of a simple coil embolization. So this is the kind of like the aneurysm that we saw in that nice diagram. So this is the example of a 3D RA. So this is a 3D rotational angiogram that you do on the theater table, and it gives you this beautiful image of the image. It's a very exact idea of what the neck is, how wide it is, what the size of the aneurysm is, if it has any blebs, and you can also see any vessels arising in the region that you need to protect. This little man here is an important thing because as you are rotating this image, it'll tell you what angle the tube needs to be at for you to be able to replicate that with an angiogram afterwards. And that angiogram will become your essentially your roadmap that you will follow for the rest of the procedure. It'll tell you where you are. So here's an aneurysm. You can see we've got a large bore catheter sitting in the ICA over here, and this is your ICA is making its turns. This is your ACA, and this is your MCA, and this is the ipsilateral A2. A1 vessel changes to A2 when it comes across the ACOM vessel. So here's the ACOM, and it's also this angiogram is also filling the contralateral A2, and you're not quite seeing the A1 on the other side because the angiogram is done from this side, and it's revealing this aneurysm in the ACOM. And what we've done is from here, we've taken a microcatheter and we've navigated it into the base of the aneurysm itself. And from here, we are starting to release some platinum coils. And a number of platinum coils are released just like that. So this is what the actual X-ray image live screen looks like. But because you've done an angiogram already, and you've asked the computer, the biplane machine, to tell you that I want you to mask this image and pretend as if I'm screening on this. So it gives you, you're actually navigating on this, whereas it actually looks like this. So it's quite a clever way of treating it. So once you've packed the aneurysm sufficiently, it thromboses off. You can see plenty of coils in there. And when you do the angiogram, voila, and the aneurysm has disappeared. All the vessels are present, and this aneurysm is treated. I'll show you an example of a couple of microaneurysms. So this is a classical hypertensive bleed that patients can get in the basal ganglia. There's a CT angiogram, shows a tiny little dot here, which is confirmed. This is not the same patient, but this is what they will look like on a DSA, a tiny microaneurysm. Because of how small these vessels are, and they're very tricky to reach into, quite often we just watch these. The only way of treating it would be to either sacrifice this vessel or go distally and occlude it. And if they are not possible for us to navigate through, and the mass effect from the hematoma is large enough that the neurosurgeon might want to go and remove the clot anyway, then they would try and resect the aneurysm at the same time. This is an interesting example of a case that we had. It was someone who came in with a acute subdural hemorrhage, and CT angiogram showed this aneurysm, which we did a DSA for, and here's this little distal aneurysm. So all the aneurysms we used to treating are around in this area, circular Willis, but this one is much further down the ACA territory. This is sort of your A4, A5 territory of the anterior cerebral artery. And on serial CT angiograms, it showed that it was increasing in size. So what we did, we used a liquid embolic agent by getting very close to the aneurysm, and you use this liquid embolic agent to slowly fill the aneurysm up with, it's like a glue-like structure. In this case, we used an embolic agent called Fill, but the others you might hear of, like Onyx, Squid, and so on and so forth, and actual glue. We can actually use medically grade glue at times to do the job. So this will deem to be the right tool for this job. And once you've filled it with the liquid embolic, you can only do this in vessels that you're happy to sacrifice, because if you did this in proximal vessels, then essentially you don't really have that much control of the glue where it goes, and you don't want it to go to embolize to territories that you don't want, and that will be catastrophic. But because in this case we got very close to the aneurysm, but we weren't able to place a coil in it, the only way we could treat it is by sacrificing that little branch and essentially getting rid of that entire segment. And you can see the DSA afterwards shows that the aneurysm has disappeared. Now, an example of when we need help from balloons and stents or coiling. So this is a 62-year-old GP, had headaches for 3 months, MRI for the headache, and showed this left ICA paraophthalmic aneurysm. Now, when you start the treatment for this aneurysm, you realize how broad the base is, and it's covering a lot of the vessel, and it's quite. As we tried to place some coils in this aneurysm with the microcatheter, we realized they were trying to sag into the main artery, and the issue was that if it continued to encroach, it would potentially um, uh, threaten the parent artery. You don't want to occlude the ICA, obviously, because then you're going to have a major stroke on that side. So what we did was we used a balloon. I'm not sure if you can appreciate it. There's a hyperdense sausage-like structure which is in the actual parent artery with contrast in the balloon. So we continued to coil with the balloon inflated, temporary balloon inflations, and in the end we got a very dense pack whilst keeping the parent artery completely open. So that's where, if we didn't have a balloon to help in that situation, you'd be fighting all day and probably will end up with some encroachment and possibly a stroke. A little word on dissecting aneurysms. Most are traumatic, iatrogenic, either we cause them or they're spontaneous. There tend to be a background of connective tissue disorders which make them more likely to have it. It often starts with a little tear in the intima, but then as the blood force shears into that space, it falls like a false lumen that you bleed into, and then it can create a very ugly looking pseudoaneurysm. And the thing to remember with these sort of things for us is that the entire segment of the artery, you can use coil, you often have to sacrifice that entire segment. Sometimes that means that it's going to result in a stroke, but it's either that or, a chance of rebleed in those cases are very high. And you have that conversation with patients, and they often choose to have the treatment. They have a propensity to affect the V3, V4 junction, that's the vertebral artery, as it enters into the skull base. This is the segment of the artery that was dissected famously in a cricketer, Australian cricketer, who was hit by a cricket ball. And this is the segment that was dissected because of direct trauma. Usually that presents as a stroke, but it can also present as dissecting aneurysm and subarachnoid hemorrhage. I'll show you an example which is not exactly the same location, but it's keeping up with the theme of the anterior cerebral artery. So here's a CT angiogram in which you can see the amount of blood load. There's a lot of blood. There's a big blood clot here, adjacent to this round aneurysmal structure. So clearly, this is this aneurysm which has bled. There was a history of trauma in this patient, and she was poor grade multi-compartmental hemorrhage, ventricular hemorrhage, as you can see in the fourth ventricle here, third ventricle, lateral ventricle. So doing the 3D angiogram in our treatment, we found this very ugly looking aneurysm. So this is your ICA, and that's your MCA looking very normal. But your ACA, the entire segment looks diseased, and there's this big pseudoaneurysm sticking out, poking into where the big blood clot was. So the only way of treating this would be to actually treat off this entire artery segment. So this is what we did. So this is the angiogram during the study. So you can see it looks horrible. But the trouble here is that this ACA on this side is also supplying the rest of the ipsilateral ACA territory. But because we know there's some contrast is spilling over to the other side, the right A1 from the left A1 tells us that there's a good ACOM artery, which meant that it allowed us to safely occlude this without worrying about a stroke. So we essentially filled that segment with coils, as you can see on there. And ultimately, doing an angiogram on this side, you're not seeing the left ACA at all. But to show that actually that still exists, when you go on the other side, the angiogram from the right ICA demonstrates that actually both ACA vessels are patent. As you can see, the distal ACA territories bilaterally are filling. So that's your dissecting aneurysms. The giant aneurysms are completely different kettle of fish. They are sort of on somewhat of similar theme to the last case. Quite often, when they're that big, the best treatment option is to actually sacrifice the vessel if the patient can take it. So this is probably the biggest aneurysm I've personally ever treated. This is there's a young man with pulmonary TB with poor self-hygiene who essentially presented with, who was scanned to look for signs of CNS TB because of a headache and ophthalmoplegia, and they saw this tennis ball size of an aneurysm in his head. The entire sac size is about 5 centimeters by 4 centimeters, but you can see that the filling segment is just this bit here. Even that in itself is very large. The rest of it is already thrombosed. Now, when you look at the, you can see the lateral view, that there's a big filling segment of this aneurysm. This is the distal ICA. and the right-hand side with a big thrombosed sac. This is the 3D angiogram view where it looks, again, equally as horrible. There is a very important artery coming here which supplies the internal capsule, which essentially is where your corticospinal tract goes through. This is your anterior caudal artery. So you have to do the treatment and try and keep that artery open. Then because this entire segment of artery is diseased, the only treatment option for it really would have been either a surgical bypass, which after speaking to the neurosurgical team, they didn't think he was a good candidate for. The alternative is that we essentially treat this aneurysm with vessel sacrifice. So before you do that, what you tend to do is do what's called a balloon occlusion test. So in your internal carotid artery, lower down, what you can do, you inflate a balloon temporarily while the patient's awake, and you go on the opposite side and do an angiogram to see if there's cross-filling from the ACOM, whether it's from the ACOM or from the posterior communicating artery via the vertebral artery and the basilar artery. And if the patient has good flow across and they don't develop any clinical symptoms with the balloon inflated for over 30 minutes, they essentially pass the balloon occlusion test. What we did here is fill this entire segment with coils, and put what's called an Amplatzer plug in the lower down cervical carotid. And then in the end, when you do the angiogram from the other side, you can see that both MCA territories are simultaneously filling with only a slight half a second delay. You can see that this is filling up to that point, and that's gone beyond one more segment. But that's a normal finding. So that's how you often tackle giant aneurysm. They're not always treatable, but this is often if the patient has a good circular willis, this is a pretty elegant treatment. So now, since, like I said, in the last 20 years, the aneurysm treatment has come a long way. Just like no one knew about coil embolizations or coiling of aneurysms 10, 15 years ago, including myself when I was coming through medical school. These days, people don't know about the next level of advancements. So, which is why I'm here to show you. So these have been around for 8 to 10 years. So this is what's called a web device, stands for woven endobridge. Essentially, it's got a single layer of multiple, up to about 48 wires that are woven together. And they come in sort of pre-shaped sizes, and they're designed for wide-necked aneurysms. So where a coil might be prone to falling out and necessitate using a stent, and even then sometimes you don't get a perfect result. And the problem with the stent is that you're leaving a lot of metal in the actual parent arteries. That means the patient needs to be on dual antiplatelets for life, or for 6 months at least, and then one antiplatelet for life. And in that time, they can have complications as well. What it allows you to do is essentially, without the use of a stent or a balloon, you can size the right size of device according to the aneurysm. You use the radial force of the device to essentially hug the inside of the artery, and you open the device into the aneurysm. It's a single device. It's quite a quick treatment, and essentially it seals the aneurysm off and it causes clotting within the aneurysm. So these are called intrasaccular devices. Lots have been made of late. Webb is probably the most successful one, but because of its success, there are loads and loads of new devices coming out with different properties and different uses. The other more common one, the other two that I've used are Contour and NextStent. Contour is basically half a web. And NextStent is the same thing, but it also allows you to get through the struts and coil the aneurysm as well. I'll show you some examples of this. So this is a patient that I had actually not long ago, maybe about 2 months ago, with sort of a widespread subarachnoid hemorrhage, mainly in the anterior interhemispheric fissure, as well as in the prepontine cistern. CT angiogram showed right in the middle of that was a fairly wide neck pericallosal aneurysm. And here's a 3D angiogram showing you that. So it's a really wide neck. I was worried about losing these vessels if the coil was to encroach. So instead, what I decided to do was during the treatment, here's the guide catheter here in the neck. So you can see the DSA is showing you that wide neck of the pericallosal aneurysm. And this, with an eye of faith, you might be able to see a much finer tube called a microcatheter is just there, sitting inside of the aneurysm there. So you track the catheter using a micro wire, and then you leave the microcatheter in there, and through the microcatheter, then you deploy this device. And I'm just going to run this video. You'll see the angiogram with the device attached to my catheter, and you can see it's already causing stasis in the aneurysm. As you can see, it's not filling nearly as well as it was before, and whatever is there sort of hanging around for a little bit. That's exactly what you want to see. Once I've detached the device, you can see the catheter is back in the artery, and now that aneurysm is almost already gone straight away. Another example, this is an elective patient of mine with who was under surveillance and had a growing anterior communicating artery aneurysm. She grew this horrible looking locule on the aneurysm, which is always a bad sign. And similarly, because of how broad the base was, we decided to place a web in the aneurysm, which is now in position in there. You can see very nicely the angiogram afterwards shows that the contrast that managed to seep through the device is now sitting in that locule and is unable to get away. All the rest of the contrast is washed out, but that means that this is almost certainly going to thrombose off, and it's going to be a robust treatment for this aneurysm. This is an example that's not one of mine. It's one that I've got from the internet, but it's a very nice example of a patient who's a young female horse riding instructor, good grade SAH, and was treated with a web. And actually, they've also got we don't tend to do 6-month follow-up with DSAs. This is the immediate post-treatment. And they had a 6-month follow-up with DSA. We tend to do MRA, which shows almost a complete perfect occlusion of the aneurysm. So lots of different devices for aneurysms that were previously untreatable or very difficult to treat. Now, flow diversion is the next revolution, I would say. Again, it's been around for a long time, but it's going through its different iterations, and now it's probably in its phase where it's many different competitors are making very, very good devices. So you're starting to see the best uses of it now. It's gone beyond the experimental stage. So essentially, what this allows you to do is a very high metallic coverage, but you can appreciate from that little GIF is that there's loads of little tiny pores in it. So there are enough pores in there to keep any vessels that are arising from that segment of artery to remain open, but there's enough metal coverage that it allows the flow to be remodeled. And like the start of the talk, we talked about the etiology and how flow dynamics has a huge role to play in developing aneurysms. Changing the flow around the neck of the aneurysm completely changes how an aneurysm behaves. So what eventually happens is the aneurysm shrinks over time. These are very good treatment options particularly for unruptured aneurysms, for tiny blister aneurysms that you can't get any coils in, and for sort of very dysplastic fusiform aneurysms, again, which are untreatable otherwise. Often we also treat them for recurrent aneurysms. I'll show you some examples of that. So this is the concept, is that you've got an aneurysm here, and I think these are all flow models, not real patients. And this is a flow diverting stent. You can see it has pores in it that will keep this artery open, but it will shrink this aneurysm over time. And because this process happens slowly, it allows the artery to sort of remodel, and the collateral supply may take over from a different location. This is a prime example of that. This is a posterior inferior cerebellar artery aneurysm that was ruptured a couple of years ago that we treated with coiling. And after surveillance over time, you notice that the base of it was starting to grow, which is a concerning sign. But you can see how wide the base of the aneurysm is, and this vessel, the pica artery, is very much incorporated in the aneurysm regrowth. So it's very difficult to place some more coils in there without threatening this artery. So we thought that a flow diverting stent would be useful, a good treatment for this. This is a vessel analysis that we do during the procedure to see what kind of size of stent, what length we will need. So you can see this is part of the planning that we're seeing, that we want the stent to sit here to divert the flow away from the sac, and hopefully the vessel stays open. With the eye of faith, after deployment, you might be able to see there is a faint tubular structure just at the base of these coils, which is the flow diverting stent that I placed. And this is an interesting concept that I just talked about. So the MRI scan pre-op showed that this large occurrence at the base and this quite a dominant looking pica artery here. But after 6 months, when we did the rescan, the recurrence is almost completely gone. It's been remodeled. And that vessel is only faintly, if at all, visible. So you might think, oh, they must have had a cerebellar infarct. But actually, in fact, she's been completely asymptomatic. And on the MRI scan, there's absolutely no evidence of any damage. And it's quite often what we see is that the remodeling happens over time, and the collateral supply slowly grows and takes over the territory. Obviously, there is a risk that you might cause an occlusion, and that risk is in the order of 5 to 8%. And the risk of stroke with simple coiling is about 5%. So there's a slight increased risk. But in terms of treating things that you otherwise aren't able to do, it's not really that much of a complication penalty. But again, it's another example, another victory for flow diversion, where this is a patient that I had on my very recent bank holiday weekend, 55-year-old male, good grade subarachnoid hemorrhage. CTA was negative, but the bleed pattern on his CT scan, on this plain CT, was concerning. So I did a DSA for him, which showed this tiny anterior communicating artery blister, where there's also an important little perforator vessel coming next to it. And you can see that it's actually wider in its base and it's high. So this is only about 1.5 millimeters in depth. You can imagine trying to get a microcatheter to sit there and place a coil that's going to remain there. It's going to be, one, hazardous because you might just rupture through it, and two, is not really going to be possible because when you look at the lateral view, it's got this sort of a seat-shaped appearance. There was no way that any coil was going to sit in that. The only treatment for that is flow diversion, despite the acute phase, because we tend not to want to put things in parent arteries, generally speaking, because patients require dual antiplatelets for these stents, and when somebody's had an acute bleed, that's not something you want to do because sometimes it can make the bleed worse, particularly if the patient needs a ventricular drain putting in afterwards. That can complicate the procedure for the neurosurgeon. So we often have a MDT, a joint discussion, as we did with this patient, to see whether they've got any other treatment options for this. And it was thought the flow diversion was by far his only option and best options. This is again a treatment projection view to show you what it's going to look like. Through the DSA, where it shows that sort of a very shallow, stubby-looking aneurysm, and this is the snapshot of what the flow diverter looks like afterwards. You can see it's covering that anatomy there. We're still waiting for 6-month follow-up for this patient, but he did clinically very well. He went home as per plan for a few days of recovering from an initial bleed. This is an example of that I've taken from a paper online. It's an extreme example, but it shows that it's possible. So this is an entirely dysplastic and diseased segment of the internal carotid artery. That the only other treatment in the years gone by would be vessel sacrifice or a sort of a vessel bypass, but that's not always possible because of the rest of the anatomy. Not everybody has a complete circular Willis, so this patient did not afford to lose this artery. So instead, what they've done is treated it with a very long and telescoped flow diverting stents. And eventually, what's happened over time, you can see the entire artery has remodeled. This is immediately post-treatment, and this is after some time. You can see the entire vessel has sort of shrunk around that, around the stent, and most importantly, this vessel that's coming off at this level has remained open. So that's sort of a whistle-stop tour of sort of what we can do for aneurysms these days. The future is also exciting, and new devices and techniques are coming out to treat things that we currently are finding it difficult to treat because of the anatomical limitations or other reasons. There are other neurosurgical interventions that may in the future be doable by interventional neuroradiologists, such as I was in a conference called Brain Conference at the end of last year, where they showed how they were able to go from the venous side, go into the inferior petrosal sinus, and from there essentially puncture through and create a shunt between the CSF space and the vein to essentially as an internal ventricular drain, so to speak, as opposed to the extraventricular drain where you have to pipe through the frontal lobe. It's interesting. We are already using AI tools for our stroke work, where an AI module is introduced in all our referral sites all across East Midlands. The patient has a CT angiogram and it detects a large vessel occlusion. I get a ping on my phone even before the patient gets off the table. And I think eventually the same company that I've been working with are also working on algorithms for aneurysm detection, and it'll be just a matter of time before they can do that. And in terms of devices and catheters, there are some really interesting new developments in the field, which, if you're interested, I'd recommend going to some conferences. Brain conference that happens in London is a particularly good one for innovations if you're interested. And I think that's probably about all I'm going to say. Thank you for listening.